so that we have clear audio for everyone. So I want to welcome you to the state of the department. I want to welcome all faculty, staff, trainees, and outside visitors that have joined us for our State of the Department update. It's really a joy to see everyone. And again, we are remote, but I am hopeful that this is maybe the last full remote. I think we'll always have a hybrid model where people can log on or attend in person. And hopefully in 22, we will be doing that. I also ask if you have a burning question in the middle of anything that I or another presenter is saying and you want to ask it right away, just mic up and ask your question. If it's not so pressing, you can put it in the chat and hopefully we'll have some time to get to questions. Any questions that are in the chat that we don't get to, I promise you that I will disseminate responses to. So for today, based on some welcome feedback from last year, our format's going to be a little bit different. I keep changing this every year. I would like to emphasize that this is a highlight of many of the things that we have accomplished. I want to remind everyone, as you know, we have a newsletter that is released every month. And in that newsletter, we have important announcements, awards, publications, grants, introductions of new faculty and staff, and other important program or activity reminders or information. So I am not going to be repeating all of those introductions and recognitions today. I will highlight a higher level accomplishment and some of our major successes, but if I don't recognize a success that you personally were very much involved in, that doesn't mean it's not important. My goal is for everyone to walk away today learning something new about us. I can't include everyone or everything with a faculty of over 100 of part-time and full-time faculty plus 250 staff, many, many divisions and programs. It's just not reasonable. So bear with me. And again, I welcome feedback after today for changes for next year. I did want to start with a little note that our vice chair of research is not with us today because she has a serious family issue that she needs to attend to. And of course, family comes first, and so she won't be with us. But I want to share with you two inspiring comments that she sent me late last night. She shared two quotes and her comment about each, and I was very inspired by these and want to share them. So Leonard Bernstein said, "To achieve great things, two things are needed, a plan and not quite enough time." And isn't that true? That if you're pushed, if you're under pressure, we tend to rise to our best and do our best. Her comment about this is, I know we hear much from our colleagues about stress and being overwhelmed. But Gloria wants to say that I think this year has taught me a lot about the caliber of who we work with and what we are capable of. Those kinds of difficult times really show us who we are. And I thought that was well stated. This department has been amazing in keeping things rolling forward, dealing with unexpected challenges. It's just been amazing, and we have certainly risen to the occasion. The second quote, and only from Gloria would this come, is from Winnie the Pooh. And the quote is, "It is more fun to talk with someone who doesn't use long, difficult words, but rather short, easy words like, 'What about lunch?'" Her comment about this is, "Decades from now, I will not remember what grants I got or what papers were published. I will instead remember a Saturday in July where myself, Gloria, Teo, and others, several others in the department, dressed in holiday sweaters and sang Christmas carols to Nancy's husband on his final holiday celebration before he died. The simple way that we connect are the most meaningful ways of how we define ourselves as a team. Thank you, Gloria, for sharing these comments. That last quote hit me sort of right in the gut. Couldn't be truer. And I have to say the pandemic has challenged us as coming together as teams. It has been hard, and yet we have managed to do it. So let me share. Hopefully I can do this. There we go. Share my screen. Screen mode. Okay. Hopefully folks can see this. Great. All right. So again, welcome to the State of the Department. Here's our lineup. This presentation is a third. The first third is going to be a brief but concise and informative summary of our accomplishments in the department, including new faculty and promotions, finance, updates on the various divisions, and our community engagement. We will not be reading every single slide. These slides will be available to all of you. This talk is recorded and will be on our website if people want to take a look at it as well. And then the second third, I have invited 3 different groups of people or individuals to give us no more than 10-minute update on a topic that I think few of us know about. So again, this is the part of leaving our meeting today, learning something new about the department. So areas of interest that demonstrated really creative, innovative thinking, research, collaborations, that kind of thing. And then what was asked for from last year was, well, we heard a lot about what happened last year, but what's going to happen this year? And so I have a little bit of information on forward motion. What are our 22 priorities? So to start with, I'd like to do some recognitions. And of course, the first recognition is the loss of our dear Silas. Silas was a wonderful member of our IT team. He was with us for about 2 years. His smile, his energy, his willingness to roll up his sleeves and be involved in any problem that happened to come down the pike was incredibly helpful, appreciative, and again, he was a true team member. Silas died unexpectedly at a very young age, and he currently has been transported back to Kenya with Winnie, his wife and son, Luke, and other family members to be buried. I just want to acknowledge that many groups in the department pulled together and took up collections and donations for Winnie and in honor of Silas to help with that transport back to Kenya, because that is quite an expensive undertaking. And Winnie was really very appreciative and overwhelmed and humbled at the response and the support that she got from our department. So this is certainly a tribute to Silas. I also want to thank all of our central and business administrative teams for your support and just ability to keep things running. I say seamlessly. I think we did a pretty good job. It's always a challenge, and here's the list of all our frontline central office team, including our IT team and everyone here on the 4th floor. I want to thank each and every one of you for your hard work, your dedication, and your flexibility at sort of rolling kind of with the demands and the punches. The next thing I'd like to do is just again briefly recognize those individuals that have gone above and beyond this past year around our diversity initiatives. These individuals, as you can see on the slide, again, I'm not going to read through every single name. Here's their pictures and names you can look at, but these individuals, and there is a man there, Andre, but we don't have his picture, just incredibly resourceful, energetic, and very generous with their ideas, their time, and their energy, and helping us work out and initiate a lot of our diversity. Everybody, I hope, is involved. These individuals really sort of rose to a higher level, and I wanted to acknowledge them. So thank you very much. I also want to welcome new faculty. And again, each of these individuals have been highlighted in our newsletter with a little bio that came along with them. I'm not going to go into deep detail with each one of them. It's interesting, though, when you take a look at it, we had 13 new faculty just in the past 12 months. And again, we have a very large department, lots and lots of talent. CL, MPRC, geriatrics, child and adolescent, DPSR, Midtown, addictions, have lots of new folks. If you want more detail on all of these individuals, all of our newsletters are on the website, and you can look up more detail about them and how to get in touch with them. But welcome to all. And one thing I want to say is, you know, again, with the pandemic, most of the individuals that have joined us, I have not seen in person. Something that today, if we were having it live, we'd be able to see each other, clap for each other, that kind of thing, and not able to do that. But I want to welcome each and every one of you and hope that this turns out to be a good year for you. Faculty promotions. Another, again, great degree numbers of promotions. You all know these first three characters pretty well. We've been active and on board for more than the past year. I won't dwell on Anique, Sarah, or myself for that matter, but I do want to just highlight a couple. Congratulations to Jamie and Patrick, who finished their first probationary year, if you went, as instructor, and was they were both promoted to assistant professor. We have Seth Ahmed, who is in our department but works across departments, who was promoted to associate professor with tenure. We have another tenure promotion, Dr. Krenwall, who was full professor but is now tenured. So we have two tenured faculty this year that moved up. We have several associate professor promotions, Dr. Doty and Dr. Miller, and two professors, Dr. Weintraub and Dr. Warwick. So done a great job. We're very proud of all our faculty as we move up. I just want to highlight we are thinking more about our recruitment and our mentoring program and how to really focus on individual needs. And so more to come on that, but congratulations to everyone here. So next I want to move on and invite David Castine, who is our Director of Finance for the department, to do a quick financial overview. David?
Thank you, Jill. Good afternoon, everyone. Overall, the department generated $910,000 versus a budget of $64,000. We received a one-time rebate of $382,000 for indirect cost related to our old water loop program that dated back from FY19 and FY20. Additionally, we received state-funded Medicare upper payment limit dollars for a program to provide expanded patient access, and that was $139,000. So overall, about 62% of our favorable variance is related to one-time unbudgeted items. So I just wanted to highlight that for our overall financials, but clearly the department is in a good place for this year. But again, we always run a very lean, tight budget. So this expectation wouldn't be that we would always have this much of a margin. It was clearly generated by one-time items. Next slide, please. Here you can see a trend of our total revenue and our IDX cash collections. So here again, just a favorable trend overall, healthy department growth. And then next year we're actually anticipating that growth to increase by 12% overall for revenue. Next slide, please. Here's a visual comparison of our budget and actuals for FY21 separated into categories so you can see the funding sources. One note for research grants and contracts, this is what was actually incurred, so that means billed and posted in our financial system Quantum. from July 1st to June 30th. And this is not what was awarded or any funding that was extended. So sometimes people get confused on financially reporting on grants versus what was awarded. So I just wanted to clarify that. And that's it for me, Jill.
Thank you. Does anybody have any pressing questions for David? Okay. So let me move on. A quick update on diversity. Now, we had an entire Grand Rounds time, 90 minutes dedicated to our diversity year in review. And so I'm not going to go into the endless numbers of activities and accomplishments that we had, but to say that, you know, Dr. Forrester, you know, was formally appointed our Chief of Diversity. And we worked hard last year over having a guide for faculty and staff, by the way, establishing best practices for the interview process. We did hire 14 minority faculty, 13 were minority. We had a five-part Grand Round series, which we hope to continue next year, or this year. And again, we use Teams for channeling. We also have a diversity implementation team. And I think what's important to stress here is that leadership's important, but everyone on the faculty and staff are important in our diversity initiatives. These are not something that is one and done, or a checklist and we're finished, or 2 years and we did everything we could. This is an ongoing year after year effort of getting ourselves back in line, particularly when we serve a community in Baltimore that is predominantly of underrepresented minorities. So we have a diversity implementation team, and these are the members of it. Each division or big program has an assigned implementer. Now, the implementer is really meant as a support to the division leadership and faculty and staff of that division. So the first 6 months of this initiative, we just defined what our problem was, which was big. The second year, all of last year, we did a needs assessment and engagement and education. And this year, we're really taking those needs assessments, identifying on every level, what is our action plan and how to implement it. And the implementation team is there to provide support to the divisions for implementing that. So I want to first encourage everyone to get involved. And if you don't hear about this, ask your division director what's going on. But I also want to especially thank everyone on this team for their willingness to step forward. There was some special training. We meet monthly to talk about how it's going, what challenges, what barriers. Your input is important. Your participation is critical to our success. So thank you to the team. So our next update will be our research highlights. And I just want to, in general, thank the leaders of all of our research big teams. Obviously, Dr. Rees as our vice chair, and then in alphabetical order, Drs. Bennett, Buchanan, Goldberg, and Gould are all heads of big division research groups or centers. This is not to negate all of the research that goes on in the clinical divisions as well. But we've had lots and lots of activity and success. Overall, you can see that we had $19 million with 58 active grants, 18 active R01s. We had 5 new R01s and a supplement this past year. We had a 6% growth in our research funding. And excitedly, like, we were number 20 on the Blue Ridge, and this is a number that the School of Medicine really looks at very carefully. Every chair, every department, they highlight where they are on the Blue Ridge report. Well, last year we were number 20. There's lots of departments of psychiatry, so that is not a shabby placement. But I said, gee, I wonder if we can make it to 19. And even in the pandemic, we moved up 2 slots to 18. So we're now 18th on the Blue Ridge report, only behind the University of Chicago and Missouri. Um, we had 24 COVID-related grants and 10 were funded, which is actually a very good percent. And just at the MPRC alone, they submitted 29 grants and contract applications, including 15 NIH applications, and were awarded a new $12 million in grants. We had 233 peer-reviewed journal articles in our department across our faculty, 8 book chapters and 3 books. Very prolific, very productive. And I want to thank everyone that was contributed to this. We also we're working on a breakdown per division of research grants and service grants, but we didn't have an opportunity to get that all together, so I can provide that at a later date. Education highlights, again, under the direction of Dr. Mark Ehrenreich. Our residents have done super well, as they always do. 17 national and local awards. We have a great board pass rate. They published 26 papers and delivered 31 presentations. So we have a very active training group. Other highlights, all 4 of our fellowships were accredited. We had a successful virtual recruitment last year, and we're doing it again this year. So hopefully we'll have just as good results. Through COVID, our training programs were maintained by adjusting rotations across 8 hospitals. It was no easy feat, and there were certain people with feet on the ground that really worked hard to make this happen. Medical student education, also a huge challenge during COVID. Actually, Marissa Flaherty created 2 online elective rotations, added 3 clerkship sites, and we're expanding the sub-internship to Midtown. Clinical highlights. Again, I'm going through this quickly. Clinical highlights. So just want to touch on the various divisions and some big accomplishments. Hopefully you all know, and maybe you saw the brief video of the ribbon cutting ceremony of the new child and adolescent unit on 11 West. It is a gorgeous unit, completely trauma-informed design, both architecturally and programmatically. It is the first of its kind in the state. Very generous support from the hospital. It was a $9.5 million investment. So if you are interested in seeing the whole unit, if you go on our website, go to the child and adolescent landing page, you can click on the ribbon cutting ceremony, and at the very beginning of the ribbon cutting ceremony, the first 3 minutes is a tour of the unit, and then you can stop there. But it's a great peek at what the unit's like, and I encourage everyone to take a look at that if you didn't get a chance to see it. Across all of our clinical divisions, we had $18 million of service grants, 29 service grants. We do a phenomenal amount of work in the state. More on this in a bit. Just on to highlight a few highlights in some of the divisions. CL expanded our trauma integrated care service into the shock trauma. Partially, COVID has thrown some wrenches into that, but it desperately needed, and Maddie Marks was a big lead on that as well. Community really provided access to vaccines and voter registration with people with SMI. The Maryland Center of Excellence in Problem Gambling maintained their momentum and energy around serving the Maryland residents with presentations and gambling awareness. And I have to say on this slide, the biggest challenge for all of these was our employee assistance program that absolutely rose to the occasion. For the past 18 months, they have worked nonstop serving the workforce of our campus, Midtown campus, and other campuses, Roy. They've also expanded to pharmacy rehabilitation services. They have extended themselves to the point that they now need EAP. So we are trying to back off a bit on them. They've done a phenomenal job, again, under the leadership of Wanda Binns and Rob White. I want to thank all of them for their tremendous efforts. Midtown has established telepsychiatry in the ED. So for anyone being seen in the ED, they are seen by a psychiatrist. That their ED works very different than our one downtown. So that's a great advance. We were able to reopen the adult day hospital. And there were 2 research studies implemented at Midtown, working with Drs. Bennett and Dr. Deanna Kelly at the MPRC. So it's a nice example of the integration of research into our clinical programs. And it's exciting to certainly to see that. Our telemental health program launched its new website, and they're up on social media. So lots of things going on. In addictions, again, a very active division. There's your lineup there. People know about the Maryland Addiction Consultation Service. MACS is what we call it. It's funded by the state, and we provide under the leadership of Dr. Weintraub and his entire teams, provide addiction consultation to any provider in the state, that anyone in the state that's trying to work with somebody with an addiction, particularly trying to get them started on buprenorphine. However, we also had an expansion to called Max for Moms, awarded the better part of $1 million. PI's Chris Welsh, working with providers to care for women with substance use disorders and pregnancy. And that wasn't enough. This team doesn't seem to know when to stop. So now we're extended into the DC, and there's DACS. I love these acronyms. They drive me nuts. So it's DC Addiction Consultation Service. Again, PI is Eric Weintraub, and it is the same as our Maryland Max, but it's for DC. So the word is getting out, and the team is getting larger. Congratulations to all of them. And the last update slide for now is that I think this slide is fascinating. 30% of our faculty are involved in some form of community outreach. So the state of Maryland has 50 counties. We are in every single county in some way, shape, or form, whether it's providing clinical service, consultation, education, whatever it is, we are there across the entire state of Maryland. And this is something that I don't think most departments can tout. So, I just want to, and the dean, by the way, this year highlighted, he wanted to know what departments' involvement in community outreach was, and our very own Lisa Cleary put this together after canvassing all of the divisions and all of the faculty. So this is absolutely fantastic. So we're right on time. This is doing pretty well. I'm going to move into presentations. I just want to give people an opportunity, if you have any burning questions of anything I've said so far, unmute, mic up, and ask your question. No? I'm not knowing you guys to be so quiet. Okay. The next half hour, 10 minutes each, I will cut you guys off if you go over, is I have invited 3 brief presentations on topics that I think most people in the department don't know much or anything about. So innovative, interesting projects that I would like to, that we can hear more about. So the first project is the Health and Recovery Practice, HARP. Again, those acronyms. And this will be delivered by Dr. Eric Weintraub. Dr. Weintraub is a graduate of the University of Maryland. He got his undergrad at College Park, attended our School of Medicine, did his residency here, and joined our faculty in 1990. He has, side by side with me practically, I'm just a year ahead of him, he has climbed the ladder. He's our tremendous division director for the Division of Addiction Research and Treatment. And so, Eric, let me hand it over to you.
Okay, so you're going to move the slides?
Yep, you just tell me when you want me to advance.
Hi, everybody. I want to share a program that we started. We've been thinking about this program for approximately 10 years. It's collaboration between Department of Psychiatry and our division and the School of Medicine, predominantly the Infectious Disease Division. We've closely worked with that team as we share a lot of the same patients. You can go to the next slide, Jill.
Oh, there we go.
Yeah, so Anthony Amoroso and I have been working together on different projects for about 10 years, and he's sort of the co-eye on this project and helped create it. So you can go to the next slide. The bottom line is we have a large addiction treatment program at 1001 West Pratt Street. The hub, now you can go back on that. The hub of the program is our opioid treatment program, and we have two other substance abuse programs there, and it takes care of about 750 patients. And the basic issue is that many of our patients, and this is known in the literature, many patients with substance use disorders have chronic medical and psychiatric issues, are not part of the mainstream medical care of our country, don't go to primary care appointments. They frequently use acute settings to get treated, going to the emergency department. What we found with our patients is they like to get treated in one place. So we started to think that maybe we should set up a medical clinic within our opioid treatment program. You go to the next slide. That would allow our patients, when they're coming to get medicated and get treatment, that they would be able to also access medical and psychiatric care and other recovery services. So the program design is called a reverse co-location, integration of medical and substance abuse care to be delivered. You can read through this: culturally competent and contextually relevant site. So we want to deliver both primary care, preventive care, have walk-in appointments for acute issues. I mean, it's not uncommon where somebody would come to me for their medication-based treatment with methadone and buprenorphine and say, by the way, my back hurts, or I've got a wound on my foot, I'm walking down to the emergency room to get it treated. So we wanted to set up, and our patients are high utilizers of these acute services, and we knew that. So we wanted to get targeted medical care, case management, and provide subspecialty care for the treatment of HIV and hepatitis C. Approximately 70% of our patients, and I might be a little bit wrong about the percentage, probably have hepatitis C, and we wanted to be able to take care of that on site, and also develop recovery services like drop-in center and other services where people could sit and talk to each other, maybe get some help with vocational homelessness and other types of things that will help them move forward with their recovery. You can go to the next slide, Jill. So this is kind of the bottom line is we tried to put this together. We're having trouble. We had to put a white paper together. We were having trouble getting funding to support the program, and then Jill really helped us out here and push things forward. There was an opportunity that the university had to present some population health strategies to Maryland Medicaid that they were willing to fund through the upper payment limit system. And without getting into too much detail, what it meant was that if the dean and the medical school could come up with some programs, they would be able to bill higher rates for their physician services with Medicaid, which meant a fair amount of money for the School of Medicine. And we were able to get a reasonable, actually pretty good budget to support our program. And from that time on, the program has actually been able to take off. You can go to the next slide. So these are the services that we are providing: primary care, urgent care. We also are building a trauma-informed psychiatric program that is in its incipient stage. We have a full-time psychologist coming on. We're in the process of developing the program. I actually met with Sarah Edwards from Child, who is an expert in this area, and we're trying to gather as much expertise as we can as we get this off the ground. We provide infectious disease treatment. I'll give you a slide about the numbers on that soon. We're actually pretty actively taking care of individuals with wounds. I think we have over 25 patients with who are involved in our wound care program that are not going to the emergency room and are being treated by us. We have social work and case management services that are growing, and nurse care coordination is also being developed to help individuals with chronic medical conditions manage their care. So these are some of the I don't know how much time I have, so I'm going to go quickly. These are some of the program goals and objectives. So basically we're providing harm reduction, where we're all, and I'll talk a little bit about that later, but we're also, we're giving Narcan to patients, and we also got approved as the ability to give clean needles and syringes to our patients as well. And the goals are to decrease utilization of acute care services and address the social determinants of health. You go to the next slide, Joe. I just want to give you some numbers. We got started in late November, I think, of 2019 when we saw our first patient, and it's been complex building this program. I'll just be honest with you. And we actually got some really good news. I don't know if I've even told you yet, Jill, but Able Foundation agreed to put in $1.1 million towards the renovation of our building. We have pretty aggressive plans to really renovate the upstairs of our building, so it'll be a really nice site for our patients. But so far, we've treated 117 patients for hepatitis C. 94 have been cured, and I think the most interesting statistic is we are now treating more patients for hepatitis C than any clinic on campus, even more than the Thrive Clinic or any infectious disease clinic. Don't have as many patients with HIV, but you can see the numbers there. You want to go to the next slide, Jill, please? And then right now, 25% of our, I think that's supposed to be heart patients, have sought psychiatric care. So we have a half-time psychiatrist there now between Max Spinerna and Avi Rampashad, and they're pretty busy right now. We're also doing wound care, as I had mentioned before, and then we have our harm reduction services that are listed there. There is one other number that I have. So right now we have 188 patients active in our primary care clinic, and of our 750 patients, 452, we've had 452 unique patients that have been seen since January 2021. But the majority of them have been seen as walk-in and urgent care. So there is an issue of getting people to come regularly and consistently for their appointments. Just two last things, and then I'll open up for questions. It's become a major training site for individuals of all students and trainees of all schools. We have social work students, nurse practitioner students, medical students, fellows, addiction fellows, pain fellows, medical primary care, and psychiatric residents that all rotate through there. And we also now have a psychology intern that is working there with us. And we've got a fair amount of research going on in the building as well. But I'll kind of stop there because I'm assuming I'm getting towards the end of my time.
You are. You're out.
Okay.
So does anyone Eric, this is like, you could talk forever about this program. And I want to make one point, but I want to see, does anyone have any specific questions for Eric? This is a phenomenal program.
And I want to thank you, Jill. You did push us across the line with that by putting us forward. I don't think I never would have gotten off the ground.
Money is over $1 million. It's $1.2 million or whatever it is a year. It's a lot of money. Yeah. The thing I want to point out here is I was listening to a chair talk, the chair Bill Regime of radiology, and he said in his presentation that excellence in clinical programs leads to excellence and expansion of research and education, of course. And this is a very, very nice example of when we push ourselves to do what we know our patients need and do it right. It spawns all kinds of research and opportunities for partnership and education. And I actually just got off a call this morning at 9 o'clock with the chair of anatomy and neurobiology around the issues of addiction, basic science, and clinical and translational research. And it was just an hour full of spawning ideas. And we talked a lot about Eric and Chris Welsh and his whole team and what some of the possibilities are. So in line with what Robbie Schwartz has taught me over and over and over again, when clinical people talk to research people, phenomenal things happen, and I think that's happening here. So thank you very much, Eric. I appreciate that
Sure.
presentation.
Thanks for letting me share.
Okay, what happened to my, wait a minute. Okay, our next presentation is around a ketamine study. Now, this is, again, a nice example of researchers talking to researchers, clinical type people. So let me introduce Todd Gould. Dr. Gould is a graduate of the University of Virginia, from which he graduated in 2001. Dr. Gould joined our faculty in 2007, and he's a basic science leader in our department, in the translational labs of the MSDF building for psychiatry, and his focus is on the antidepressant drug mechanisms. So he got to talking to people in addictions and joined forces with Mimi Belcher. Dr. Belcher is a graduate of the University of California, Irvine. In 2007, she received her PhD in neurobiology and behavior. She did her postdoc at University of California, Santa Barbara, and the National Institute of Drug Abuse, and joined the faculty in 2014. She has two major areas of interest, but the one today is applying adjunct behavioral and pharmacologic strategies to improve retention in evidence-based medications for opioid use disorder treatment. She's also looking at the outcomes of telemedicine based delivery for buprenorphine treatment. But today we're going to hear about the ketamine study. Mimi, Todd, take it away.
Sure. First of all, thanks, Jill, for the opportunity to present the project. We can go to the next slide. So my role is more or less to present the background and the genesis of the project, and I apologize in advance. I'm going to go through that pretty quickly so that Dr. Belcher has sufficient time to talk about the substance of the project and the project that she's leading. Next slide, please.
Oh, wait a minute. It's not cooperating. There we go.
So for the last few years, I've been very interested in mechanism of action of ketamine as an antidepressant. And just reviewing for everyone briefly, there's been now about 2 decades, about 20 years of research that has found that ketamine, when administered as subanesthetic dose, whether that's racemic RS ketamine or S ketamine, can result in the rapid, robust, and sometimes sustained reversal of depressive symptoms. And this discovery for myself and many others as well has resulted in a reconceptualization of how depression can be treated. So at least I'm not thinking anymore about treatments that take weeks or months to work. What I'm thinking about now are treatments that take days and maybe even hours to work, even in treatment refractory patients. And there's been some work, but very limited work with the use of ketamine to treat opioid use disorder. So there's certainly an opportunity to do a lot more work in that area. Next slide, please. And so similar to what Jill was just discussing about bringing basic science researchers and clinicians together, Eric had contacted me just late January of this year, this past winter, and told me similar to what he just told us about expansion of his opioid use disorder clinic, and that he desired to have a research component to that expansion, and was pretty interested, or contacting me because he was interested in forging relationships and possible collaborations with basic scientists in the department. So we organized a meeting up on top of the folks in Eric's group, Max Moderna, Aaron Greenblatt, and Mimi Belcher, who attended the meeting. And then basic scientists from our department, including myself and Panos Zanos, Sarah Park, and Greg Elmer attended. And early on in the meeting, Eric talked about the greatest need, the greatest clinical need that he saw and potential to make a difference, and that was with retention. So what he told us was that folks that are on methadone, it tends to work, but the greatest problem is keeping folks coming back and retained. And then on our end, we talked about work that was going on in my group and Dr. Zanos's group related to ketamine as an antidepressant, and particularly work by Dr. Zanos's group related to overlap between depression and drug abuse, and the potential for treatments that are effective for treating depression to treat components, whether it's comorbidity with depression or negative affective symptoms that co-occur with opioid withdrawal. So I think with that, I'll stop and hand things over to Mimi to talk about the next steps. Things are going.
Thank you, Todd. Next slide, please, Jill. Thank you. And so as Todd was describing, the thinking guiding this work is that ketamine treatment could be a useful adjunct for methadone for the treatment of opioid use disorder. And the reason here is that there's a high degree of overlap between opioid use disorder and depressive symptoms. So I'm showing you data from our own clinic here. We approached 59 new intakes. Just to illustrate this point, we approached 59 new intakes to methadone treatment using a convenient sampling approach. We had no exclusionary criteria, so really a nice representative sample of the patient population here at 1001. And consenting participants were given the PHQ-9 assessment, which is a reliable and valid measure of depression severity. And you see here on the pie chart, 85% of the patients scored as likely having some form of depression. In fact, the largest percentage, 27%, fell into the category of highest severity, so a really high rate of comorbidity. Data which would suggest that a therapeutic targeting of depressive symptoms would be well indicated for this population. But as Todd indicated, when we were planning this study, we all had a really keen interest in targeting this great clinical outcome of interest for us, and that's that of retention in methadone treatment. The reason we care about this so much is that, you know, there's this overwhelming body of evidence indicating that people who stay in treatment actually stay alive. And so retaining people is of prime clinical importance. And unfortunately, methadone treatment retention is notoriously low, particularly during the first few weeks of treatment. This is true of our own population here at 1001. So for these same 59 people, we tracked how long they remained in treatment for up to 6 months. And you see clearly the precipitous dropout rate in the earliest days following intake. And that line, that 14-day time point, you just really get a nice impression of how vulnerable those earliest phases of treatment really are. And this is work in collaboration with Dr. Melanie Bennett. This is just a pilot study that we ran several months, a couple months before COVID hit. But these data square well with other reports of methadone treatment retention. And so we hypothesized that effective frontline treatment of, you know, the anhedonia, the negative affect, the depressive symptoms that you see that are associated with opioid use disorder, and particularly targeted during this, you know, earliest phases of treatment, may increase the likelihood of retaining people in treatment for the long term. So we applied and we won an intramural award from the UMB Center for Addiction Research, Education and Services, or CARES group here at UMB. And the proposal that we wrote was to run a pilot study to test a ketamine intervention, one that's been quite well rigorously tested in other populations and shown to be very effective for treatment of depression and depressive symptoms. Let's see. Yeah, next slide, please. It's important to note that ketamine research is not really focused, I just want to make that point, it's not really focused historically on a low-income, disenfranchised, housing unstable population, and particularly one that is receiving treatment for a substance use disorder. So in addition to our clinical outcomes of interest of retention, treatment, and depression, we built some implementation aims into the proposal. So you hear, you can read, the first specific aim is to test feasibility and acceptability of delivering this type of intervention into an ethno-racially diverse, largely low-income, largely housing unstable patient population. And our second aim is to measure the impact of this intervention on treatment retention and on depression. Next slide. please, Jill. And this is just a very rough, very gross course timeline of the duration of the study for each individual participant. So we're recruiting new intakes who are seeking methadone treatment on their first day in the clinic. The total duration for each subject will be 1 month, and we have a planned total of 10 study contacts, 6 of which will be in red arrows here, the actual ketamine intervention. And the intervention itself is a 2-week, every other day regimen of 6 infusions of 0.5 mg per kg ketamine, which is a sub-anesthetic regimen that Todd has described as being very effective for treatment of depressive symptoms in other populations. So we obtained the funds in July, so we're really only a few months into the implementation of this, but we've made some really, I'd like to think that they're very strong strides in this very short time. Very proud of them. We've submitted the protocol to the IRB, and they met yesterday, full table review, and so I expect we'll be hearing steps soon from them. The 45-page protocol and request for an IND waiver are sitting at the FDA offices, and we're also waiting to hear back from them on that. But we've received approval to run the study at the GCRC, which was a necessary first step. We've obtained clinical trial registration and an NIH certificate of confidentiality. And I hope we'll be in front of you soon, perhaps in the next year or so we can tell you about the exciting outcomes. And so next slide, please, Jill. And I think I'm still on time of speed talking. I'm nervous about that guillotine. My final one is one that shows the whole multidisciplinary team. And in particular, I'd like to acknowledge Dr. Eric Weintraub for your bold vision with this idea and confidence in me and in the whole team. Dr. Gold for unwavering support. And I just want to mention, this is really, really a strong team, but 2 colleagues in particular. Dr. Sarah Catacuzzi, who's an infectious disease and OUD treatment expert who's working with me on the medical side of this program, and Ms. Heather Fitzsimmons in the middle row here next to me. She just joined our division a few months ago, and she's just been a great partner in helping us move the more granular aspects of this trial forward. And we would not be able to do this without either of them, but the whole team just really thrilled. And thank you very much, Jill, for this opportunity. I guess we'll take questions. Thank you.
Thank you, Mimi. That was great. That's a nice, quick synopsis so people have an idea of the process and the tremendous opportunities for some really innovative work. Questions for Todd or Mimi?
Yes, this is David Gorelick. I'm just curious if you could outline your rationale for choosing a intravenous experimental formulation rather than the FDA-approved intranasal formulation. Seems to me, especially in this population, which may have poor venous access and be hard to have them sit around for infusions and so on. Anyway, go ahead.
I will just say that we went back and forth on this discussion several times, and you're absolutely right. That's actually going to be an exclusionary criterion as vein patency. Todd, can I pass this over to you, though, because the rationale was really scientifically justified.
Yeah, I could talk quite a while about this. My take on the existing literature is that the racemic ketamine exerts more consistent effects compared to the intranasal delivery route. Early on, the early S-ketamine trials were IV administered drug, and the results, in my view, were pretty similar to those are IV administration of racemic ketamine. And then the later trials changed to the intranasal administration route, and it actually, the approval just squeaked by FDA. There were 1 or 2 failed trials that failed to show superiority of F-ketamine versus placebo. So the bottom line is we chose that route, at least in part, because we felt that there's stronger evidence for robust effects with the intravenous administration route versus the intranasal route.
David, does that answer your question?
Yeah, I mean, as an educational point, illustrates clinical research is always a tension between scientific rigor and validity and clinical practicability. All I say is I hope you made the right choice.
Thank you for that. Anybody else have any other questions for Mimi or Todd? Thank you to the whole team. Again, a fabulous example of bringing people together, thinking outside the box. What are creative, outside the realm of maybe standard of care? That's what leads us to new findings. So, it's a great example. Thank you very, very much. All right, and our third presentation, very much down a different path, is from Dr. Peter Kochanov of the MPRC. Dr. Kochanov graduated from the University of Texas Health Science Center in San Antonio, where he received his PhD in medical physics. He joined the MPRC and our faculty in 2011. And his focus of work is using imaging genetics to understand complex polygenic nature of psychiatric illness, such as schizophrenia. So we have invited Dr. Kochanov to talk to us about his most recent work and the grants that he has around this. He got 2 big grants around this. So Dr. Kochanov.
All right. Thank you so very much for kind words and introduction. Shall we proceed?
Absolutely.
And I think we can move to the next one. So I am not a clinician. I have to make that strong disclaimer. I'm a physicist by training, and from my point of view, the state of current psychiatric science is a pretty low one. It's in the cellar among the wines and spirits. Why is it in the cellar among wines and spirits? Well, because the diagnosis is primarily based on clinical features, and so many of them are shared across disorders. There is a lot of unexplained heterogeneity that enters into clinical presentation, including age and type of onset, signs and symptoms, course of illness, and treatment response. Most of the science is being performed within diagnostic silos, which is contrary to the previous point, given how common the sharing of symptom occurs in individual people. We still have no objective post-mortem or ante-mortem test to rule in or rule out a particular disorder. And if we start looking at the polygenic inheritance, we see that a lot of risk factors are prominently shared across disorders. There is also sharing of environmental risk factors, including stress and childhood adversity. And then, of course, there is a paucity of adequate animal models. So one approach to deal with so much uncertainty is to start using big data studies that have collected large and representative samples to see if there is any commonality across people with specific disorders, and try to develop some sort of measures that use those big data, basically informed by those big data studies, to help us to start making sense of what we see in an individual. And next slide, please. So the goal, I think the foundation of psychiatric science that has been missing for quite a while is reproducibility. So for quite a while, the psychiatric genetics was all about candidate genes. I mean, psychiatric genetics is not the only one at a flaw, but it has been all about candidate genes. So let me give you a good example. The COMT was a very hot target for schizophrenia candidate genes from from late 90s. It's a protein that has a very nicely aligned function. It degrades catecholamines, including dopamine, and maintains homeostasis of neurotransmitters. It has a functional variant that is common, and the gene was discovered in a deletion-like symptoms, which raises the risk of schizophrenia-like symptoms by 30 times. And there has been over 700 publications on the topic of effect of this polymorphism in schizophrenia and bipolar disorder. Next slide, please. But what actually happens if we look at the big data results? So the PGC finding in 150,000 subjects found that that particular variant, despite being hailed as a breakthrough and despite being identified as highly important by small studies, actually exerts no effect whatsoever in the schizophrenia in general. The relative risk ratios are about as non-significant as it gets, suggesting that an entire industry of researchers have been laboring for a very long time and with no apparent outcome when it comes to the general predictive abilities. And next slide, please. So I am thinking that we are entering the era of big data and personalized risks driven by basically understanding that unless we can find reproducible findings, unless we can find generalizable findings, unless we can inform our decisions, scientific decisions based on those data, it will be very difficult for us to go forward and sort of, continue to improve the field of science. So, for instance, a neural net can recognize a photo of a cat based on the empirical knowledge collected through training of simple internet searches. So what we propose to do is to develop approaches that basically use genome and imaging data collected in large samples such as UK Biobank to provide us with some assessment of personalized risk for any individual, because that risk can be present in controls, it can be present across disorders, because we simply are quite arbitrary when it comes to assigning clinical diagnosis. Next slide, please. So what the grants are focused are on data-driven individual vulnerability estimation. So the entry variable becomes the imaging MRI scans of the brain. The support variables become the patterns of brain deficits obtained from large and inclusive worldwide studies to remove variants that are associated with collection site, individual heterogeneity, treatment heterogeneity, localized differences. So in essence, we get the patterns that remain after all existing treatments and independent of local biases in diagnostic varieties, hopefully thereby averaging the effects that are indeed common and present across people who suffer from mental illnesses. And our output variable is simple. It's similarity to the expected pattern. Next slide, please. So the foundation of this grant is that our work with Enigma demonstrates that, for instance, brain deficit patterns in schizophrenia, major depressive disorder, bipolar disorder, and other illnesses from large N studies are highly reproducible in independent cohorts. In other words, if we choose a pattern of brain deficits across the entire brain and then look at the predictive ability of that pattern in an independent cohort, we obtain a very good correlation with those numbers. And again, the effect sizes are highly variable. Previously we all gone after effect sizes. Does it replicate the effect sizes? No, we can't replicate the effect sizes, but what we can replicate is that we can replicate the patterns. I think in many ways it's a very sensible realization, because let's look at the diagnosis of diabetes, like type 2 diabetes. Type 2 diabetes is best diagnosed by the pattern of the elevated blood glucose across the day and night cycle, rather than just going around by a single measurement and saying, well, the glucose is above a certain number, say 120 milliliters, therefore it's type 2 diabetes, obviously. No, what we want to do is have somebody's blood monitored continuously, and then we can actually say whether there is a change in the temporal patterns of the glucose in the blood that is indicative of the type 2 diabetes. And the similarity with that pattern is what would determine the severity of the diabetes in an individual. Next slide, please. So one of the projects that NIH has provided us with funds for is to derive agreement indices between the regional brain patterns and large N indices for major psychiatric and major neurological conditions such as schizophrenia, bipolar disorder, major depressive disorder, epilepsy, Alzheimer's disease, Parkinson's disease, and then compare simple linear approaches to derive that similarity to the machine learning, to the more advanced machine learning and artificial intelligence indices. And then one of our goals is to provide those indices for the Human Connectome project, and specifically for the Human Connectome projects in disorders. Next slide, please.
I think that was your last slide.
Okay, and sorry, I forgot to acknowledge my collaborators, including Elliot Hong and collaborators at NPRC, as well as collaborators in Enigma, collaborators basically worldwide that make this research possible.
Dr. Kochanov, that was fascinating. Quite a different way of looking at how to understand how to diagnose the illness. That was fabulous. Anybody have any questions for? Can't imagine handling questions in this complex area. Anybody have questions for Dr. Kochanov? Thank you very much, Dr. Kochanov. So again, we had 3 presentations, very different contexts and content to demonstrate the breadth of work that we do in this department and the successes that we are having in the advancement. So it's very exciting to hear about. And I want to thank all 3 groups of our speakers for contributing today. Okay, so the last part of this presentation, which I don't think will take a whole lot of time, is there was a request for future goals, or goals, what is our priorities for the FY22 academic year. So I thought I would sort of briefly just give a quick update on, in each of these categories, what are we focusing on right now? Now, this doesn't reflect necessarily every individual's focus in their work, but sort of from a departmental perspective. So in the realm of research, I am focusing on actively recruiting 1 or 2 additional clinical investigators. We brought on 2 last year, and I would like to bring on 1 or 2 more clinical investigators this year to support our translational work from bench to bed, and also to expand our repertoire from more into the realm of addiction, affective stress disorders. So we're focusing on that. I would like to bring on another basic science investigator, thinking along the lines of partnering with Dr. Gould and our NPRC basic science investigators. But really, we have a couple of gaps, and possibly in addictions, again, more work in affective disorders or stress, but we need another basic science researcher there for sure this coming year. Another big item that we're working on in the department is the relocation planning for the next one is that I think most people know. We've made an announcement that Dr. Robert Buchanan will be stepping down as the director of NPRC. He's the second of only two directors we've had for the MPRC over 40 years, Dr. Will Carpenter, who's on this call, as well as Dr. Buchanan. So we are recruiting. There's a search committee up and running. The last report I got is they have at least 12 promising candidates, and that search is ongoing. Along with that, we are formulating plans to relocate the MPRC to the downtown campus. Why? The state has made it very clear that their intention is to consolidate and reorganize the mental health services in the state, including looking at the state facilities, and Spring Grove over time is slated to be closed. That, coupled with a new director, coupled with the gradual, steady, and actually increasingly decline of the facilities at Spring Grove, all of that lends itself to us really rethinking the relocation of the MPRC somewhere on the downtown or around the downtown campus. We are working with the state of Maryland. We have met with the health department. There are active conversations going on right now with the Secretary of Health, with the campus, and with the School of Medicine. So just to say that that will be a project that occurs over a series of years, not all at once. And I think that it will present many increased opportunities to have the MPRC on the downtown campus. It will help with some of these other things that I have listed here. Continued growth in our translational programs, including, again, stress, affective disorders, and addictions, in addition to continuing to enhance our work in psychosis. There is also, in talking with meeting with the MPRC leadership team just Tuesday, I think it was, the idea of setting up a premier specialty clinic in psychosis actually could be a great opportunity with all the expertise. Couple that with all our expertise we have in the Division of Community Psychiatry, where we treat people with serious mental illness. It could be a great partnership. We want to strengthen our relationships with substance abuse and pregnancy programs in the Department of Anatomy and Neurobiology, and I mentioned that earlier, that I had a meeting just this morning with Dr. Saf Keller, their chair. Great ideas, great opportunities. It's very exciting, and he's a chair that is definitely open to finding a way to share and collaborate so that it's a win-win. I will say that we are going to be actively participating. Nobody knows this yet, including the Division of Addictions, but we're going to be actively participating and co-sponsoring a symposium in addiction during pregnancy. It'll be a national and international symposium, and we're going to be partnering with Anatomy and Neurobiology to facilitate this. There is the Center for the SUP, is the Substance Use in Pregnancy Program in Anatomy and Neurobiology, that is sort of leading the way in that symposium, but it's a very exciting opportunity. We want to continue to expand our collaborations with College Park, UMBC, the Department of Radiology, Anatomy and Neurobiology, and many others. I think our growth is in our massive clinical enterprise that partners with all the researchers and education. And so, again, under the leadership of all the research division directors that already had relationships, plus Gloria's incredible ability to connect with people, we've really made headway this year, and I hope that to continue. I mentioned the Blue Ridge report earlier, and I said, well, we were 20, let's try to get to 19, and we got to 18. I wonder if we could get to 17 this year. It's just kind of an idea. And then the last thing I want everyone to be aware of is that the dean announced yesterday, with the approval of the campus, Bruce Jarrell, our president, with the establishment of CARTI, which is the Center for Advanced Research Training and Innovation. This is, in fact, an extension and an improvement on the existence research career development program through the School of Medicine. So CAR-T will be through the School of Medicine. It'll be an extension of that. And it will be for the purposes of supporting developing researchers, specifically fellows going into faculty. It is not for high school students. It's not for graduate students per se, but it's for higher level going into junior faculty. One of the advantages is that there's many advantages to it, and we'll get much more information, but they will have CAR-T counselors that can meet one-on-one with a junior person that's trying to get their self catapulted. Now, I see this program working hand in hand with our mentorship program that Dr. Deanna Kelly and Dr. Gloria Reeves and the whole committee put together. So this is just another resource for us. So in research, that's kind of where we're going. Again, I haven't mentioned all the stuff going on in child and addictions and you know, other areas where research is developing. In education, we will again continue our virtual recruitment. We are conducting some groundwork, Dr. Chris Morano, to stand up a geriatric neurocognitive fellowship. So that groundwork is starting. And we want to continue our physician science training program. We have been incredibly successful. For those of you that had the opportunity, we had another presentation last night of one of our fellows, or our residents. Really interesting work. So we want to continue that in our education, along with everything else, all our fellowships and support of all our residents. In the clinical realm, I am actively recruiting 2 faculty educators, clinical educators for 12 West, the downtown unit. Dr. Lou Cohen is stepping down at the end of this academic year, and we're recruiting for a new medical director of the PA practice. And we're redesigning that practice to help provide more support to the faculty that work in the PA. We're redesigning and integrating research initiatives and practices into our clinical programs, and we have a committee that has met once and comprised of both clinicians and researchers to say, okay, what does this look like? We are using our MPRC model as a successful model of how do you do this, so that we can do more integration and collaboration downtown and benefit our faculty, our staff, and our patients. So again, excellent clinical programs leads to innovative and spawns lots of research ideas, and then can support research initiatives. We'll continue our partnership with GBRICS and the state and the HSCRC to enhance crisis response and care in mental health in the city and surrounding counties. And slated for January, we have a single point of entry for adult ambulatory programs, an intake clinic, if you will. It's the old Carter Center Screening Clinic, reborn. And under consideration, again, I've been approached by a donor about mother-baby, mother-family wellness program. I do know that there's lots of interest in this. St. Joe's is interested in us expanding up there, so those are some possibilities. Department-wide, we are all working on establishing our new normal. And, you know, I started this hour and a half out talking about how we define ourselves as a team. And the one thing that the pandemic has done is stressed and challenged our teams. And so our new normal is getting back to work, getting back to collaborating, working as a team, being collegial. And so I know there's a lot of angst around coming back to the office. Honestly, our biggest problem is people that may be exposed at home and bringing it to work. And so I just want to encourage everybody to sort of go with the flow. We all need to be vaccinated. Flu shots are available now. Don't forget to get your flu shot. Walk in to the auditorium and you can get it. Be safe, be conscientious, and let's kind of reestablish our connections. I have already talked about departmental-wide, the diversity, equity, and inclusion priorities and action plans at every level. everyone, and this is not some extra big project on the side. This is how do we integrate diversity, equity, and inclusion into our daily work and thinking. And I think on sort of a higher leadership level, I really want to see us, and I think we have in many, many ways, but continue to move from I to we, from strengthening ourselves and moving into a culture of voice. And I will say that I started with this 2 years ago. I've encouraged people to be verbal. I've encouraged people to be vocal about ideas they have to improve things. And I have gotten a lot of response to that. And so I think we're going in the right direction. And the last thing I want to say, and I think this is probably the most important to everybody on this call, and that is maximizing our departmental intelligence. And what do I mean by that? Well, if you look at the corporate literature, they have demonstrated that corporations that are led from the ground up, that include the ideas, initiatives, energy, and leadership, not just from the top, but from everybody along across the continuum of our department, they do better. They're more successful. Corporations and companies and organizations, including health organizations, that just lead from the top and mandate down, actually eventually spit her out, whatever. They don't do well, and they're not the best places for employees to keep working. And when I look around our department, I see, and that was my last slide, so I'm going to stop sharing and open up the screen, but I see talent that is untapped. I see incredible ability, incredible ideas, thinking outside the box. It's just amazing to me. If I have a problem, I'm sitting in my office, I think, okay, who can I go talk to? Who has ideas about this? And so that is our departmental intelligence. And I would like all of us to work at accessing the intelligence around us in a much more active way. That is moving from I to we. It's not my priority. It's not my idea. It's our priorities. It's our ideas. How are we going to be successful? Like we've always been successful, as you saw in our presentations today, by collaborating and talking and joining efforts. And so I think I just want to stop talking there and say that's where I see our department going this year. It has been a phenomenal year for me and a learning year, and I hope we move into the next. So we only have 5 minutes left, but we stayed in on time. I will invite anybody that wants to comment or question, but before I do that, I just want to say, if you have feedback about this format today, too much, too little, lose this, gain that, please email me. I'm open to suggestions. So let me stop there. If anyone has anything you'd like to say, questions you'd like to ask, please do so. And it's a big group, so it's feels kind of weird sometimes, but go ahead.
Well, Jill, I don't have a question, but I have a compliment. I thought this was an outstanding state of the department, both in structure and in the content. And in fact, I got many more than one new thing or takeaway. So I'm going to generate a few emails later on today to the relevant people, but thank you again.
Thank you, David. Fantastic. I'm glad to hear that. I appreciate that. Other comments, other ideas, other thoughts?
Hi, Jill. This is Ben. I just wanted to say thanks for your words, and I have felt so welcomed here. And what you say about moving from I to we is something I realize I've been missing and have started to find here. So thank you, and just so glad to be able to hear what was shared today.
Thank you, Ben. Ben Israel is one of our new folks, and Ben is 60% time, and I think that means he wants to be 100% time. Thank you, Ben. It's great having you on, having you back.
You had to go there, huh?
I had to go there. No pressure. No, it's been great having you on. We have a number of new folks on board, and it's been fabulous. Other thoughts, other reactions? What I leave? No, I'm not going to ask what I left out. I left out a lot. Forget that question. Any other comments? Okay. Well, why don't we end there? Thank you, everyone. I think we had a total of 190 people on this call, so that was fantastic. And enjoy the rest of your week, and share your ideas with me, please. Thank you. Bye-bye.